7 minutes will be conducted by the moderator. The moderator will be either myself or Dr. Waqas Shafiq. The first 3 cases will be done by Dr. Waqas. The last case will be done by myself. And during those 7 minutes, the house will be opened up to the panelists, our worthy panelists first, who I will introduce very shortly. In those 7 minutes, the panelists will give their views about the case. If they want to pose a question to the trainee, they are more than welcome to do so. That's the aim of this exercise. The answers will be given by the trainee. After that, during the 3 to 4 minutes, while the panelists are giving their views one by one, the audience is more than welcome to post their questions or their comments in the Q&A box, which by the time we finish with the 3 panelists for that particular case, the moderator will then throw those questions or comments to the trainee. So everything will be answered by the trainee. It's part of their learning. So that will be the format, and hopefully we should end in an hour and 10-15 minutes, inshallah. So that's the format. All 3 panelists have been given a numbering sheet, a rubric for rating the trainees, which I've shared on the group. And I request all the worthy panelists to mark them along as we go along. And towards the end, when the last trainee is done, just take a picture of your sheet and WhatsApp me so that I can do the total and we can then announce the winner. So that's the format. And now, last but not the least, before I zip my mouth up, is to introduce the 3 worthy panelists who have joined us from across Pakistan. There is no need to introduce them. They are very well known, very well respected, senior most icons of our country in endocrinology. We have Dr. Abbas Raza from Lahore. We have Colonel Shahid from Pindi, and we have Professor Zaman Sheikh from Karachi. So a very warm welcome to all 3 of you and taking your time out for this endeavor. Thank you very much. So without any further ado, over to Waqas, and I'm just going to be an observer from now. Over to you, Waqas.
Thank you. Thanks, Atif. So now I'm going to request Dr. Sabiha Bano from Aga Khan Hospital to start with her case. So Sabiha, okay, over to you. You can start sharing your screen.
So are my slides visible?
Yes.
So hello everyone, I'm Dr. Sabiha from Aga Khan University Hospital. My case is a young female with secondary amenorrhea and hirsutism. So the patient's history and examination: 25-year-old female patient presented with secondary amenorrhea for 5 years, raised blood pressure for 2 years, hirsutism for last 5 years, and weight gain. Documented weight gain. On examination, blood pressure was 149 by 103 millimeter of mercury. Pulse is 72 beats per minute. BMI calculated is 27.6. On examination, there were no stria, no proximal myopathy, acanthosis nigricans. Thyroid was not palpable. Hirsutism is present on the face and body. We calculated the Ferriman-Galvez score, found to be very high, 25. Mild temporal baldness is present. So she was workup. The investigation revealed the prolactin of 23.3 with the reference range is 3.8 to 23 nanogram per deciliter. FSH is 0.76 with the reference range is 1.4 to 9.9 milli-international unit per ml. LH is 0.14. Testosterone is sky high, 526.9 with the normal upper limit is 48 nanogram per deciliter. TSH is 2.8. Free T4 is normal. Dihydroepiandrosterone sulfate level was done, which was turned out to be normal, 147. The upper limit is up to 430 microgram per deciliter. 17-hydroxyprogesterone was checked, which was high, 10.9 nanogram per ml. The upper limit is up to 0.7 nanogram per ml. Overnight low-dose dexamethasone suppression test was done, which turned out to be normal. The value is 0.7. Hemoglobin is 18.2 with hematocrit is 53.7, on which the further workup was done. The JAK2 mutation was checked as per hematologist consultation, which turned out to be negative. So this slide showing the high testosterone level with high 17-hydroxyprogesterone level and suppressed FSH-LH. So the patients further worked up with the CT scan pelvis with contrast, which revealed there is a large left ovarian mass adherent to sigmoid colon, abutting the fundus of uterus and right ovary. There is no evidence of peritoneal disease, abdominopelvic lymphadenopathy, or no distant metastasis. The size of mass was 87 into 52 millimeter as per our radiologist. So you can see the huge mass in this slide. On right-sided view, this is the coronal image which showed there is a huge ill-defined heterogeneously enhancing mass, which is 87 into 87 as pointed by arrowhead, 87 into 52 millimeter, and it is from the left ovarian extending up to the compressing the uterine fundus and extending to the right ovary, and it is also abutting the colon. So this is mass. It is compressing the ovary and extending to the right side. As per radiologist, right side of the ovary is also bulky, and it is about 42 into 27 millimeter. So I hope everyone can appreciate this mass. So the patient finally underwent laparotomy and left-sided salpingo-oophorectomy and bilateral pelvic lymphadenectomy. Histopathology of left-sided ovarian mass finally turned out to be consistent with steroid cell tumor of ovary. So this is the histopathological slide. On image A, you can see the tumor cells are arranged in sheets. The image B, this is the low power field, image A. Image B reveals there are rounded to polygonal cells which are arranged, and there is abundant eosinophilic cytoplasm with prominent nuclei. There are no nuclear atypia, no mitosis seen, and there is abundant clear eosinophilic cytoplasm. The cells have the uniform border. So in post-op follow-up after surgery, the patient's secondary amenorrhea resolved after 3 months of surgery. She resumed regular cycles. Hirsutism resolved after 3 months. And initially, the patient was hypertensive and was on single oral antihypertensive agent. After surgery, in the clinic follow-up, she became normotensive and off antihypertensive. Testosterone is 526 pre-op, and now it's 3 months post-op is 46. We also check 1 month post-op testosterone level, which was 25. 17-hydroxyprogesterone pre-op is 10.9, and now post-op it's 0.5. And again, 2 months after surgery, it was 0.5. Hemoglobin and hematocrit initially 18.2 and 53.7 respectively. Now the polycythemia has resolved. Note she underwent also 1 session of phlebotomy. So conclusion of this case is, if you ever get any patient who present with virilization, should be investigated systematically to determine from where the high testosterone level is coming, whether it is of adrenal origin or considered as a cause of virilization, especially in 3rd and 4th decade aged females. So discussion points are: what are the other causes of similar presentation? Why there was raised blood pressure in my patient? Why 17-hydroxyprogesterone level is raised and dihydroepiandrosterone sulfate level is within normal limits? And why there is polycythemia in this female patient?
Thank you. Thank you, Dr. Sabiha.
Thank you,
So
sir.
now I'm going to ask these questions from you first. So you tell me what can be the other causes of similar presentation.
So what the other causes of similar presentation as my patient has could be the hyperandrogenism in young females. Second differential would be non-classic congenital adrenal hyperplasia. The other differential, we can keep the drug-induced hyperandrogenism And the other differential beside this could be the adrenal tumors, which can cause such degree of virilization.
Okay. So what sort of adrenal tumor normally cause that sort of presentation?
Like adrenal malignancies, adrenocortical carcinomas.
Yes, perfect. That's very good. Okay, that's very good question. Why there is raised blood pressure? So do you know the answer?
I did the literature search,
Mhm.
and as per research and literature search, uh, exact mechanism is not known, but there is sympathetic mechanism which then leads to increased blood pressures. But exact what happened at the molecular level is still not known in the rat models. This is what I found till now. Basically, this hyperandrogenism causes the sympathetic nervous system activation, then this leads to the hypertension. And it fits in my case. And another thought process I was having because of like increased red cell mass, because of excessive erythropoiesis can also contribute to hypertension. This is my second thought, but this was not given in the literature search.
Okay. Well, I don't know the answer of this one. So well done. You have done some search. But yes, I don't know. And that's very interesting why the blood pressure is raised in this patient. But we will have
And
a...
that got normalized after surgery, 3 months after surgery of antihypertensive. And
Was
another
it
thing,
only one? Was it only one occasion that the blood pressure was raised, or was it raised in all occasions?
3 clinic visits pre-op.
Okay. Okay.
And uh, one thing we didn't worked up for like secondary other causes, like Cushing was ruled out. Pheochromocytoma was not in our differential because the history doesn't fit in pheo. And another thing, potassium level was normal. So other causes were not dig out of young hypertension.
Okay. Good. So coming to your third question. So yes. So 17-hydroxyprogesterone and DHEA was raised. Sorry, 17-hydroxy was raised and DHEA was normal. And why was that?
Because dehydroepiandrosterone level, if you go to physiology, the 98% production of dehydroepiandrosterone sulfate is from the adrenal gland. Only while the ovary produce only 20% of dehydroepiandrosterone sulfate level. That's why if it would be the adrenal tumor, then the dehydroepiandrosterone level would be sky high.
Yes. And that's the reason
That's
how, for example, your other differential, for example, if it was coming from adrenal, then you will have raised testosterone and DHEA. But in your
yes.
case, because it was coming not from adrenal, so it was not raised. So coming to your last question, why there is a polycythemia in this case?
So in a steroid cell tumor of ovary, because of excessive androgen productions, this excessive androgen production stimulates the erythropoiesis. That leads to secondary polycythemia. And another thing, the tumor causes the production of increased apokine, which then causes secondary polycythemia. So two mechanisms I got.
Yes, that's very good. Because that's one of the reason why when people...
Yes.
So now I'm going to thank you, Dr. Sabia. Now I'm going to ask our panelists. They can ask you a question or can comment on it. So first I will request Dr. Abbas.
Thank you, Vikas. And I think it was a very good effort. Hats off to Sabiha for doing such a wonderful job. My question would be, if you go to your slide where you are showing the lab reports, can you go over there? Can you go back 2 or 3 slides?
This is
No, before that, the lab test report file.
the pre-op.
The pre-op labs,
One.
exactly.
My screen.
Dr. Sabia, your slides are not moving. So go back to your...
That's
yes,
perfect.
this one.
Perfect. So Sabia, if you go look, if you look at this slide where you're showing investigation, and you did the CT scan, and the CT scan didn't show the tumor, what would you do?
If the CT scan would have not shown the, then then another option is to think for other differentials, or another thought process is to get the ovarian adrenal venous sampling to find out from where it's coming.
Okay, but again, can you see, do you usually see a big, large tumor in anyone who's having an hyperandrogenism in an older female or even a younger female? Do you usually see an adrenal tumor, or you can see just the thickening of the ovaries and the enlargement of the ovaries?
Yes, if I get the thickness of the ovaries, then it is called as the hypertrichosis of ovary.
And then what would you do?
Then it would be labeled as hypertrichosis of ovary, and we can proceed with the histopath biopsy to label it.
Sure. Over to you, Vikas.
Okay, now I will request Dr. Shahid. Dr. Shahid, you can ask the question or pass a comment.
Very good presentation by Dr. Sabiha. A very good case.
Thank you, sir.
From the history, it is obvious that it was, history suggests that it was an acquired disorder. But many times we see cases of congenital adrenal hyperplasia presenting late, or with non-classical congenital adrenal hyperplasia with significant androgen secretion.
Yes.
So if it was a congenital adrenal hyperplasia presenting late, what would be the difference in presentation in this case? What do you think?
So if this, yes, if this was
If it
a
had
case
been
of non-classic congenital adrenal hyperplasia,
presenting late to the clinic, yeah, what would have been the difference?
so yes, then in that case, the menstrual cycles, the differences would be the menstrual cycle will be the regular and a high Ferriman-Galvez score, and then we get the 17-hydroxyprogesterone stimulation test with ACTH, which will be high, and in that case, in those patients with non-classic CH, the steroidism.
No, what would be the difference in the presentation?
Difference in presentation would be the regular cycles, but hirsutism, but to a lesser degree of hirsutism, not such a high severe degree of hirsutism.
Okay. With significant androgen secretion due to congenital adrenal hyperplasia, usually the problem is since from birth, and there is usually ambiguous genitalia or severe virilization in the genital area also. Patient may present with significant chloromegaly or ambiguous genitalia, or
yes,
that would have been the difference in presentation.
In classic variety. Yes, sir, in classic.
In classic or in non-classical with significant secretion, you can also get clitoromegaly.
Okay.
So the difference here, in this patient,
Voice.
probably in this patient, you did not mention, but probably in this patient, there were no significant virilization effects in the genital area. That suggests that it was an acquired disorder. Yeah.
Yes.
Good. Okay, Vikas.
Okay, now I'll request Dr. Zaman Sheikh, please. Dr. Zaman.
Sorry, now can you hear me?
Yes, yes, Dr. Zaman.
Okay. Thank you very much. First of all, hats off to efforts of Dr. Atif Munir and Dr. Vikas for this excellent academic session, rather brainstorming session. And congratulations, Dr. Sabiha Banu, for your excellent presentation. I have got few questions for you. Was family history important in this patient? You didn't mention family history because negative family history is also important.
Yes, family history is important. There was no family history in this case. Family history is important regarding the context of congenital adrenal hyperplasia.
Okay, number one. Number two, in history, you mentioned that amenorrhea, secondary amenorrhea, was for 5 years. And other problem like hirsutism and
Yes.
other problem, they started 2 years. So how you will explain the time difference? Secondary amenorrhea for 5 years and other clinical features for 2 years. Is there any explanation? Hello?
Yes, sir.
Because it's a tumor and 3 year gap between two symptoms. And this is not a case of simple hirsutism, it is a case of virilization. And we know only few causes. We can count on fingertips, a few causes of virilization. She's a case of virilization. So can you tell, virilization means tumor, means 3 year cannot be explained between period problem and other clinical features. Hello?
So for the female patient was a menstrual cycle. That's why might be she noticed this point earlier, and the hirsutism point she noticed might be later on because the main concern was cycles. That's might be the third reason behind it.
Facial appearance is more important for young females. They must have noted some degree of hirsutism. It's okay. Okay, I don't think polycythemia per se will cause hypertension. Okay. So there must be some reason. Do you think this hypertension may be related directly to this case and maybe some different pathology? Why not? Was aldosterone renin you thought to be done?
Sir, it was not checked because there was no hypokalemia, and she was only on single antihypertensive agent, and that's why. And Cushing was ruled out, and this was not the history for pheochromocytoma, so that the pheochromocytoma workup was not done.
Okay, my third and last question: 17-hydroxyprogesterone is quite high, 10. And I agree with you, in rare cases, ovarian tumor can cause it. But you yourself said that 98% is adrenal cause. So did you try to do ACTH stimulation test to further rule out? Or I don't know whether gene mutation, CYP21A2 is done in your city. I don't know, in Karachi, I mean. I don't know, because this will confirm the test for congenital adrenal hyperplasia. Do you try to rule out ACTH stimulation and to see what happens to 17-hydroxyprogesterone?
In this case, ACTH stimulation to look for high 17-progesterone was not done, and that genetic mutation is not available in our setup. It was not done.
Okay, good. Thank you.
Thank you, sir.
Thank you very much. Thank you, everyone. So I think we are already running a bit late. Looking at the question that the few people have asked why JAK2 mutation was done. I think that was because you were thinking of other causes for polycythemia, but then later on you found that it is secondary to testosterone. Is that right, Dr. Sabiha?
Hyperandrogenism.
Yes.
Yes, sir, that's why. And because we linked it to the hyperandrogenism, but initially we called the hematologist and they advised to do the JAK mutation, which turned out to be normal. Even epokine level was checked, that turned out to be normal.
And okay, and the other question was regarding either there was any adrenal lesion. So what I remember from your slides, adrenal were normal when you did the CT abdomen and pelvis.
Yes, so it was not done with the adrenal protocol, but adrenal were reported as normal.
But
both adrenals were normal.
Okay, that's great. So I think that's great.
Sorry, Atif, Waqas, can I suggest something?
Yes, please.
If you all agree, can we request our presenter to switch on the camera, because we want to see the confidence, at least during their talk, not otherwise. We want to see confidence in their face their body language, their facial expression, their confidence level. So if you agree, it's not essential. They can switch on camera during their talk at least.
I think that's a really good idea. So I think we can request from the next presenter to, if possible, to keep the camera on as well. So our judges can see them as well. So thank you, Dr. Sabiha. Now I will request Dr. Hera Irfan from Shaukat Khanum Hospital to start her case. And Hera, if you can on your camera as well.
And Dr. Sabia, you can now stop your screen sharing so that Hera can start her screen sharing. Thank you.
So I have stopped.
Thank you.
Hello, Assalamu alaikum everyone. Can everyone see me and hear me?
Yes.
I'll start my screen. Assalamu alaikum everyone. I'm Dr. Hera Irfan from Shaukat Khanum Memorial Cancer Hospital. Today I will be discussing a case of dopamine agonist-induced cerebrospinal fluid rhinorrhea. My case is about a 29-year-old female from Afghanistan who is married and have 2 children. Initially, she presented with galactorrhea and secondary amenorrhea for 7 months, headache and decreased vision for the last 1 month. On initial examination in the clinic, she was hemodynamically stable. The only positive finding was galactorrhea from her left breast on expression. Visual field examination was normal. By confrontation method in the clinic, there was no acromegalic or Cushingoid feature at that time. We ordered her initial investigations. Her prolactin was raised to 188 nanogram per milliliter with low FSH and LH, and the rest of the pituitary profile was normal. We ordered her MRI brain. This is the MRI brain of the patient that showed a cellular and supracellular mass of size 4.5 into 3.8 and 2.8 centimeter, extending inferiorly to sphenoid sinus and superiorly to hypothalamus. This mass was causing a mass effect on optic chiasm. At this time, considering the large size of the mass, her prolactin level was not appropriately raised. We ruled out hook phenomena were serial dilutions and there was no change in prolactin level. At this point, we have 2 differential diagnoses. One was prolactinoma, causing a minor increase in prolactin, and the other one was non-pituitary macroadenoma, non-functioning pituitary macroadenoma with a stalk effect causing mild increase in prolactin level. We discussed our patient in neuro-oncology MDT. Considering her clinical features, her laboratory findings, and her imaging of the brain, we decided to treat the patient as prolactinoma with dopamine agonist therapy. So we started the patient on bromocriptine for prolactinoma. Cabergoline was not offered as patient was non-affording. We initially started dose with 2.5 milligram 3 times a day and slowly titrated it to 7.5 milligram 3 times a day. After 1 month, she presented with clear rhinorrhea from her left nostril. At that time, patient did not report any history of upper respiratory tract infection, any history of surgery or trauma. At the visit in the clinic, she reported that she had improvement in her initial symptoms. Her galactorrhea, visual field, and headache has improved, but she has still not regained her normalcy. Physical examination in the clinic was normal at this time. We ordered her investigation. Her prolactin level has decreased from 188 to 14.3 nanogram per deciliter, and thyroid profile was normal. Her cortisol was normal, and serum sodium was also 140 millimole. To confirm a diagnosis of CSF rhinorrhea, we did some brain imaging. This is the CT scan of the patient. As we can see, there is a bony defect in the cellular floor or superior wall of sphenoid sinus through which the tumor is making its way to the sphenoid sinus. Again, this is the MRI which was done at this time, and that shows T2 hyperintense fluid in the sphenoid sinus with the similar intensity as CSF, worrisome for CSF leak to the defect in cellular floor. The size of the mass was reported in this scan was 3.5 centimeter against the previous dimensions of 4.5 centimeter. We took neurosurgical team on board, and she was started on acetazolamide 250 milligram twice a day. And then she was called for follow-up. On follow-up visit, she reported improvement in her clinical symptoms. her rhinorrhea has improved. So it was decided by neurosurgical team to continue patient on medical treatment. But after 1 month, she again presented with altermentation, fever, and neck rigidity. She also reported intermittent rhinorrhea. According to her, she was not very compliant with her medication. Her investigations were repeated, and at that time, her prolactin was 310 nanogram per milliliter, and CSF analysis was suggestive of bacterial meningitis with low glucose and raised proteins, neutrophilic leukocytosis. She was admitted and started for meningitis treatment, and again, she was planned for repair of defect responsible for CSF rhinorrhea. She then underwent endoscopic transsphenoidal debulking of pituitary adenoma and repair of dural defect with facial lateral graft from the right thigh. Postoperatively, she has a stable recovery, but later she developed diabetes insipidus and secondary hypothyroidism, for which she was started on desmopressin and thyroxine. On follow-up visits, she had improvement in her symptoms. Her galactorrhea has resolved, her vision has improved, and her headache has improved, but she has not started her menses yet. She never had any visual perimetry done. There was no recurrence of rhinorrhea. Her prolactin level dropped to 10 nanogram per milliliter. Her MRI brain on a follow-up visit revealed a residual pituitary mass of size 2.5 centimeter. As we can see in this image, this is a follow-up image. There are post-surgical changes in sphenoid sinus, and there was a mass in the cellular floor. So take-home message from today's case is, as we all know, dopamine agonists are the mainstay of treatment for prolactinomas. Patient may really present with cerebrospinal fluid rhinorrhea after starting therapy with dopamine agonists in the case of massive or invasive prolactinoma. So initial close follow-up is advised, and such patients should be counseled about symptoms of CSF rhinorrhea, and they should be told that they have to report immediately to doctors in the case of symptoms develop. They should be treated as soon as possible with surgical repair in order to avoid life-threatening complications, that is meningitis, that unfortunately carries high mortality and morbidity. So my today's discussion points will be, what is the reliable cutoff prolactin level for diagnosis of prolactinoma? Can CSF rhinorrhea be prevented? And what is the best investigation for detection of CSF rhinorrhea, either brain imaging or laboratory test? And what is the role of conservative management in the treatment of CSF rhinorrhea? Thank you.
Thank you, Dr. Hira. So I'm going to ask you the same question, which you put in the discussion. So let's start with the first one.
Okay, as in our case, we saw that patients' prolactin like mass was really big and prolactin level was not appropriately raised. So I did some literature search, and in which I found that there is no cutoff value for prolactin to be raised for prolactinoma. Ideally, we see that in adenomas, prolactin level increases with the size of adenoma. But in some prolactinomas, which are not very well differentiated, prolactin is not very highly raised. So actually a study was done in Oxford Center of Endocrinology and Diabetes, where they selected 226 patients, and they studied them, and they saw that 94 microgram per liter, which is equivalent to 94 nanogram per deciliter, is a safe cutoff value for prolactin to differentiate between prolactin and prolactinoma.
Okay. However, in your case, the tumor was significantly large. So
Yes.
Technically, we expect much higher level, but that's fair enough. So you mentioned about, can CSF rhinorrhea be prevented? So what's your thoughts are?
My thoughts are CSF rhinorrhea cannot be prevented because with the dopamine agonist, prolactinoma responds very well, and we expect tumor shrinkage. And when tumor shrinkage occurs, the gap in the bony defect also is also unplugged, and that causes CSF leak from arachnoid space into the nasal cavity. So, but however, we can we can initially closely follow the patient, and then at that time we can detect the CSF rhinorrhea immediately, and then we can reduce the dose of dopamine agonist and then plan for surgical repair.
Yes, and I think here
So basically,
the patient education will be very important, that you warn the patient that in case if you have any clear fluid coming from the nose, you need to report to the
Yes,
endocrine team immediately. And what about is there any difference between bromocriptine and cabergoline in causing CSF rhinorrhea? Is there any literature about it?
in the literature, there is no clear documentation of the difference between cabergoline or bromocriptine. But however, many case reports which I studied and many studies which are done, they have seen that bromocriptine has been widely used, maybe due to cost effectiveness, or maybe because in our part of the world, cabergoline is not very readily available. So they use bromocriptine in other countries as well. So many patients reported with CSF rhinorrhea were using bromocriptine initially, but there is no clear documentation whether it is due to cabergoline. Either cabergoline causes more CSF rhinorrhea or bromocriptine.
Okay. So best investigation for detection of CSF rhinorrhea.
There are two kinds of investigations. One is laboratory findings, which we can do on nasal secretions. These include the identification of glucose in the nasal secretions, which should be greater than 30 milligram, as is, we found it in CSF. And the other one is beta-2 transferrin, which is very significant, which is very specific to CSF findings. And the other thing is imaging. Nuclear medicine imaging, including CSF cysternography, can be done, but we didn't do that in our case. And then brain imaging are very diagnostic for detecting CSF rhinorrhea. And also brain imaging also helps neurologists in deciding for resection or for surgical repair of the patient. So I think both of them can be safely done, either laboratory or CSF imaging studies can be done for diagnosis of CSF rhinorrhea.
Okay, so the last thing, role of conservative management. By this you mean acetazolamide in and surgery? Is that you mean patch?
Yes.
Or the acetazolamide? So which one is better?
Which one? Actually, what I mean to ask is that, is there any role of acetazolamide in the treatment of CSF rhinorrhea, or we should already plan patient for surgical repair? Because as we see in our case, we didn't plan patient for surgical repair, and we decided to continue treatment of acetazolamide, which in turn, in the end, the patient landed with meningitis with the complication, and then ultimately we have to do CSF, we have to do repair of the patient. So, as far as I think, there should be no conservative management. Patient should be offered definitive treatment, which is surgical repair of the defect.
Is there any recommendations in any guidelines that which one we should go, or should we go straight to the patching?
According to guidelines, surgical repair is the definitive treatment, and conservative management is only offered to the patients who are waiting for the surgery or who are unfit for the surgery.
And which guideline
there were some guidelines from the Endocrine Society. So,
do they suggest that we should not use acetazolamide, or do this and straight away go to the patching?
Yes, they said straight away go to the patching.
Okay, that's great. So now over to thank you, Dr. Hera. Now over to Dr. Abbas.
Thank you, Vikas. Hera, wonderful job. Excellent case presentation, and I think you went through everything. But hind vision is always 20/20. And again, looking back, we can always find problems, and we can always find what could be done. So this patient comes to you tomorrow in your clinic. Would you do anything differently?
So in diagnosis or in management, or hello?
So would you treat this patient any differently stepwise if he comes to your clinic tomorrow? If she comes to your clinic tomorrow?
First of all, I will discuss regarding the use of cabergoline, or the options regarding switching her to cabergoline. Secondly, I will ensure compliance to the patient. I will stress on the compliance of the medication. And so these are all I will do. And then repeated follow-up.
Okay. So Hera, let me just try to explain it to you again. So do you think you could have, again, it's never in medicine. So what I'm asking is, do you think you could have done something different, or did you do something which was probably not appropriate for this patient in your practice. Obviously, I
Connection, there
don't
is some
mean
problem.
that this. Can you hear me? Can you hear
Yes,
me
sir,
now?
I can hear. Yes, sir, I can hear you.
Okay, so what I'm trying to say is that do you think you can go back in this case and say that probably I would have done this differently with this patient?
Yes, sir. First of all, I would have decreased the dose of bromocriptine initially when she presented with CSF rhinorrhea, but in this case, this was not decreased. And secondly, I would have immediately planned the patient for surgical repair instead of continue her treatment on acetazolamide.
Thank you. Exactly what I was asking. Thank you.
Dr. Shahid?
I have one question. I think it was the same question as Dr. Abbas was asking. This patient presented with an invasive pituitary tumor, which was compressing optic chiasma and making a hole in sphenoid sinus also. Prolactin was not very high, which suggested that that might not be a prolactinoma. Why was surgery not done in the first place?
So because as we have discussed that prolactin level, in some prolactinomas, prolactin is not very raised. Like these prolactinomas are undifferentiated. So we cannot know before just on the MRI findings that either this is differentiated prolactinoma or undifferentiated. So the all panel decided to first continue with medical therapy because dopamine agonist therapy, we all know that they decrease the tumor size as it did in our case. Tumor size was initially decreased.
But there was an urgency in the management of this case due to compression of the optic chiasma and due to invasive nature of the tumor. There was an urgency, and not very high prolactin was also suggesting that it may be a non-functional tumor, which is causing hyperprolactinemia due to stop compression.
So basically, the VN at that time in the clinic, but even by confrontation method was not was normal, and patient never had her visual perimetry done formal. Maybe if she had done that, then we can see that her.
Why was it not done?
So as I mentioned previously, patient was from Afghanistan, so she was not very. Her follow-up was very erratic, and these patients are not very educated. They have many border-related issues. They have many language barriers. They do have. So maybe that's why she didn't go for visual perimetry. Although we stressed on every clinical visit for her to have visual perimetry done.
Okay. Over to you, Akas.
Thank you. Dr. Zaman, please.
Dr. Zaman, you have to unmute.
Can you hear me now?
Yes.
Yes, sir.
Okay. Dr. Hirarfan, I congratulate you for excellent presentation, like previous one by Dr. Sabia Banu. I have got one or two short queries and one comment. After initial clinical and biochemical remission, she apparently was recovering after bromocriptine. Then suddenly, after that, she started rhinorrhea. So did you check compliance of the patient for taking the drugs? Because bromocriptine type drugs, they also shrink the size of the tumor. Instead of shrinking, they expanded and started rhinorrhea. So did you check compliance of the patient? Number one. And number two, the size of the tumor, 4/5 prolactin level is 300, which was later when rhinorrhea started. Initially, even less than 300. So there is an apparent mismatch between level of the prolactin and size of the tumor, and such an aggressive tumor eroding the bone. Second and third, I've got one comment about conservative therapy. If there is low volume leak, so we can counsel the patient about bed rest, head bed elevation to 30 degrees, coughing, sneezing, nose blowing, and heavy lifting should be avoided. I think we should counsel them. for low volume rhinorrhea plus prevention for further rhinorrhea.
Okay, sir. Over to your first question. When the patient presented in the clinic with CSF rhinorrhea, at that time she was on bromocriptine 7.5 milligram 3 times a day. At that time, we did her MRI brain that shows the reduction in the tumor that showed that she was compliant with the medication. Only with the reduction in the tumor, there was unplugging of the gap that causes a leak from brain to nasal cavity. So this shows that she was compliant to the medication. And secondly, maybe at that time when she presented with prolactin level of 310, at that time she was not taking her, as I mentioned in my case, that she was not very compliant with her medication. So at that time there was a rise in prolactin level. And so for conservative management, yes, for the time being when the patient has been planned for the surgery and she is waiting for her surgery, we should counsel the patient about these conservative maneuvers, like do not like head elevation, because such patients report CSF rhinorrhea more on lying flat. And in the clinic, that's why her clinical examination was unremarkable, because so, but
Okay,
definitely,
good. Thank you. Good.
thank you, sir.
Okay, Dr. Hira, there are a few questions and comment in the question and answer session. So there is one due to tumor extension. I think you have answered this, but can you please answer this again? Why you think it was
Yes.
not extension?
As I mentioned before also, that when the tumor is extending, it is plugging the gap which is due to the invasive erosion of the bony defect. Tumor is plugging the gap between CSF, between arachnoid space and nasal cavity. So when we give patient bromocriptine or cabergoline, this gap is unplugged, that causes a leak from arachnoid space into the sphenoid sinus and then through the nasal opening into the nasal cavity.
Okay. There is a comment that either why we didn't use the cabergoline, or my question, I think I asked before, was which one is better in preventing? This probably I am going to ask this question from our panelists. In their experience, is bromocriptine cause more CSF rhinorrhea as compared to cabergoline? From
So
our
again,
panelists.
Vikas, if I could answer this first, I don't think there's enough data to say that. And I don't think this will be a justified answer in any ways, because whatever will, it's similar to this case, whatever will shrink the tumor more will cause rhinorrhea more if it's unplugging it. So I don't think it's the, then again, if you look at most of the data, cabergoline has a very good safety profile as well as treatment efficacy when we look at it. So I don't know if there will ever be a chance that you can clearly compare head to head both.
Thank you.
Can I say something? I
Yes,
endorse
please.
Abbas Raza. And in my opinion, cabergoline is better because compliance, once weekly dose, compliance is more. And in my personal experience, cabergoline has got less side effect than bromocriptine, nausea, vomiting type.
Thank you, Dr. Zaman. Okay, thank you, Dr.
Thank you, sir.
So I'm going to ask our third speaker. That's Dr. Paras Imran from JPMC. Dr. Paras, you can share the screen and start the presentation, please.
Thank you, Dr. Vikas. Is my screen visible to everybody?
Yes.
Yes.
Assalamu alaikum, everybody. This is Dr. Paras Imran. I'm working as an endocrinology fellow at Jinnah Postgraduate Medical Center and Medicine Institute of Diabetes, Endocrinology and Metabolism. So today's topic of my case is Graves' disease and orbitopathy in association with active acromegaly. This case is of 40 years old female, single, known case of Graves' disease and orbitopathy for last 4 years, who presented to us with complaints of increase in size of hand and feet and blurring of vision for last 6 months. Her follow-up was very erratic for thyroid disease, and every time she presented, thyroid function tests were at toxic levels. She had a regular menstrual cycle. Her drug history included neomercazole at a dose of 15 milligram BID, and in her family history, she has 2 brothers and 1 sister, all were doing well. On examination, patient had a BP of 110 by 70 millimeter mercury with a BMI of 23.8 kilogram per meter square. Further, on general physical examination, she looked to be anemic and a slate gray skin pigmentation was seen all over. She had acromegalic features, and neck examination, we could appreciate grade 3 non-tender multinodular goiter, and she had significant orbitopathy with clinical activity score of 5. So these images have been shared with the consent of patient, and this image is of around 10 years back from today. And this is the recent image of a patient. As you can appreciate, acromegalic features and coarsening of the features, swelling of the lips, prognathism is seen, and marked orbitopathy is observed with frontal bossing, and generalized slate gray skin pigmentation was seen. Further, neck examination, patient has had a large multinodular goiter. On investigation, she had a TSH of 0.01 with raised FT4 of 5.13, FT3 of 26.69. Her TRAB antibodies were positive with a titer of 47. However, anti-TPO and anti-TG were negative. Since we had clinical evidence of acromegaly, so we proceeded with the initial screening test and we proceeded with IGF-1. IGF-1 was found to be markedly elevated with a value of 877.6 nanogram per ml. Her FSH, ALH, estradiol, prolactin, ACTH were within normal limits. Cortisol was 14.6 and HbA1c was found to be in the impaired range with a value of 5.8%. Since it was a large goiter, so we proceeded with ultrasound thyroid, and it was reported as a large multinodular goiter with no suspicious features. Thyroid scintigraphy was done, which showed diffuse uptake with a solitary cold nodule in the left lobe of thyroid gland. Since she was anemic and we were looking for association of one autoimmune disease with another, so we got celiac serology done and it was also found to be negative. Surveillance for acromegaly was done, which included DEXA scan, colonoscopy, and echo. All were found to be normal. So keeping in view evidence, clinical and biochemical evidence of acromegaly, we proceeded with our line of investigations, and then we began with imaging. As you can see, MRI pituitary coronal section, and pituitary gland was found to be within the, it was normal. There was no evidence of any adenoma within the pituitary. So pituitary gland was normal in size. On dynamic images, no differentially enhancing area was seen within it. Another MRI was repeated at an interval of around 1 year. And it was again, just as you can see, slightly bulky pituitary here, but no evidence of adenoma again. On sagittal section also, there was no evidence of pituitary adenoma. So it was reported as bulky, homogeneously enhancing, no adenoma, and pituitary stalk was central, minimal depression of pituitary floor seen, and pituitary hyperplasia was there. So just now when we did not find any evidence of pituitary tumor on MRI, we went on searching for the source of this growth hormone secreting tumor. We then proceeded with the ectopic search for ectopic secretion of growth hormone secreting tumor. In that context, CT scan neck, chest, and abdomen was done, and which showed that apart from thyroid orbitopathy and large multinodular goiter, there was no evidence of enhancing lesion in pancreas or sympathetic chain to suggest neuroendocrine tumor. So case resolution and follow-up is that since patient is currently at very toxic level, and our plan is to proceed with total thyroidectomy once she becomes euthyroid. Follow-up after that is to optimize thyroid replacement therapy after thyroidectomy and active vitamin D and calcium replacement for PTH deficiency in case of accidental removal of parathyroid. Her Graves' orbitopathy has improved significantly. When she presented first, she had clinical activity score of 5, and after receiving 6 weeks of bolus therapy of methylprednisolone, mycophenolate mofetil, and selenium, last follow-up visit when she presented, her clinical activity score was slightly improved, and we are planning on to continue with the methylprednisolone, mycophenolate, and selenium for a few more months. And if there's a relapse of Graves' orbitopathy seen, we have options of escalating treatment and adding on with monoclonal antibodies such as tocilizumab or more recently approved drug, teprotumab. So teprotumab is a recently FDA approved drug for Graves' orbitopathy, but it's not available in our part of world, and cost is the main issue. It's a very costly drug, and its mechanism is also would also help us in treating acromegaly, as it is IGF-1 receptor antagonist monoclonal antibody. So in the hunt of growth hormone releasing hormone secreting tumor, we proceeded with DOTA TET scan, which has been done, but report is still awaited. And in the meanwhile, we are trying to control the symptoms of excess growth hormone with medical treatment until source of growth hormone releasing hormone is identified and removed. So long-term follow-up is in terms of surveillance for acromegaly. We will keep a check on serum IGF-1 level, echo, DEXA scan, and colonoscopy as guidelines suggest. And surveillance for Graves' ophthalmopathy would be done in terms of symptoms and checking out clinical activity score on each visit, clinical examination, and TRAB level if indicated. So a few things I would like to discuss with my worthy panelists is the reason for increased skin pigmentation and options for managing thyrotoxicosis further, search for a source of ectopic GHRH secretion.
Thank you. So my question to you will be reason for skin pigmentation. So what you have found?
So initially we were thinking while getting the workup done, we were thinking in terms of maybe there is some ACTHoma or MSHoma, which is leading to this much of the skin pigmentation. But as the workup unrevealed, her ACTH was found to be within the normal limits. And since we know that MSH is precursor and we cannot biochemically quantify it, we do not have lab availability to check that hormone. Since ACTH was normal, so we assumed this was not because of ACTHoma or MSHoma.
Okay.
So
and your second option for managing thyrotoxicosis further?
So we have certain options for thyrotoxicosis generally, like antithyroid drugs and radioactive iodine. But in this patient with significant Graves' orbitopathy, radioactive iodine is not an option. She's already on antithyroid drugs. So we are planning on for total thyroidectomy once she achieves the euthyroid level. And that would help perhaps with her orbitopathy also, because removal of that thyroid tissue would probably lead to improvement in eye disease as well.
So how long you have been treating thyrotoxicosis with antithyroid medication?
Actually, as I mentioned in my history, she had a very erratic follow-up. She has started coming to us regularly for last 4 to 5 months. And that's how we are following her with her thyroid function test. And currently she's on neomercazole also. And we are making sure to ensure compliance and everything. So she had
Okay.
erratic follow-up initially, but now since 4 to 5 months, she has been coming to us regularly.
Okay. And you showed us in your slides regarding the thyroid scan, which showed that there was a diffuse uptake. Was it a diffuse increase uptake?
Yeah, there was in the left lobe, there was a cold nodule. And apart from that, there was a diffused increased uptake in the remaining thyroid gland.
Okay. Okay. So regarding the search for ectopic, you have already searched for it and you have already requested DOTA scan as well. If you still unable to find the source, how will you follow this patient? How frequently will you consider imaging this patient to look for the source?
Since we do not have any evidence of tumor so far, so let's see what DOTA has to reveal. But in the meanwhile, we can control her symptoms and biochemically active acromegaly with medical therapy, which we are doing right now. And plan is to continue monitoring her IGF-1 level at least every 6 months to annually, and other follow-up of acromegaly is to be done as indicated in the guidelines.
So what you are giving at the minute in terms of
Uh,
medical management?
we have started her on somatostatin analogs. We are giving her octreotide once monthly, and it's been 2 months so far.
Okay. And is there any improvement or it's too early?
I think it's too early to say that. Clinically, her Graves' orbitopathy has improved, and we have not checked her IGF-1 level after starting octreotide. We are planning to do that in next couple of months.
Okay, that's great. Thank you. So over to Dr. Abbas.
Again, a wonderful presentation, and again, hats off for the effort, Paras. Let me ask you a question, which is not perfectly related to this patient, but again, someone coming in with Graves' orbitopathy and typical Graves' symptoms, and you're treating them for that. But this person is developing increased pigmentation, number one. He's developing some signs of growth hormone excess. Is there any other medical condition which can give you a similar picture? Just which you can think of as someone who's getting pigmentation and features of some growth hormone excess?
There's one condition called Carney disease, and that there are different tumors in the different areas of body that can result in growth hormone producing tumors, generalized skin pigmentation, myxomas, and medullary. It can present with medullary thyroid CA also. So if we try to fit in our patient, we have 3 criteria from that, but no evidence of tumor elsewhere in the body. Like on echo, there is no evidence of any atrial myxoma or anything that sort of. And keeping in view this Graves' disease, we know that one autoimmune condition can be associated with another, like Addison's disease can present with skin pigmentation, but we have a completely normal cortisol. She doesn't have any evidence of Addison's. ACTH is also normal.
Fair enough. And again, the other thing that you can potentially look in someone else other than maybe her is insulin resistance as well, because they can also give you acanthosis, sometimes darkening of the skin, and some features of pseudoacromegaly as well because of the growth hormone and insulin receptors. Over to you.
Thank you. Now, Dr. Shahid, please. Dr. Shahid.
Yes, I have one comment. It was a very nice presentation, and my acromegaly due to ectopic growth hormone or growth hormone releasing hormone is very rare, and there is the pituitary gland visible on MRI. So have you with a better MRI? Was it done with 3 Tesla? Dr. Paras?
No, sir, it was not. We just repeated the, sorry, sir?
I think if you do a better MRI with a
Hello?
3 Tesla
Yes.
machine, or I think if you do a better MRI pituitary with a 3 Tesla machine, with a better pituitary protocol, you may find a macroadenoma which is secreting a growth hormone in this case, because we see a bulky pituitary gland.
Yeah. Sir, this was
So,
done with the
because,
pituitary
yeah.
protocol. Yeah.
Hmm.
And we could just see this pituitary hyperplasia, no adenoma, but I would take in your suggestion and we would consult with radiologist further regarding this mode of MRI.
And what do you think? Why was the nodularity in the thyroid gland in a patient of Graves' disease?
So there's constantly there's constant stimulation by the as we can see that TRAB level is high, and there's constant stimulation upon the thyroid gland.
Hey, don't you think acromegaly causes multinodal goiter?
It can so in the biochemical evidence, the rest of the hormones which we screened for anterior pituitary, they were found out to be normal.
No, growth hormone is a glycoprotein hormone, and it has some
Yes,
uh,
some,
thyrotropic activity, and it
yeah,
increases the size of the thyroid.
yeah,
That is why
exactly.
this patient
Yeah,
has
that's the
significant
dynamic
goiter.
test with IGF-1
Yes,
binding proteins
and that
also,
is
and
why,
sorry,
and that is why
TRH
your
also.
yes, and that is why
Yeah,
your decision of thyroidectomy would be useful in this patient, because
right,
in this patient the size would not regress with anti-thyroid drug management. Okay,
right.
thank you. Over to you, Vikas.
Thank you. Dr. Zaman, please.
Okay, Wakas, thank you. Another nice presentation by Dr. Paras. Now, I've got one or two queries. In Grave disease, we know it is slow. And you mentioned particularly in it from the question of Kanar Shahid. Okay, you found one cold nodule. How large it is, it was not mentioned. Have you elaborated, tried to explore it further? Because it's not part of grave disease, obviously.
Yeah,
And this is one thing. And number two, you said she was clinically very much thyrotoxic, but dose given was only 15 milligram twice a day, means 3 tablets 2 times a day, maybe. So this is very small dose as compared with the level of clinical and biochemical thyrotoxicity. So why there is this mismatch?
okay, so coming to your first question, when we found out cold nodule on a thyroid scintigraphy, we advised patient for FNAC, but as I told that she was very irregular with her follow-up, she could not comply with that. And second question, those about regarding the dose of neomercazole. Simultaneously, we started her on methylprednisolone also for her orbitopathy, expecting that some of the inflammation would be controlled by that also. Because in our clinics, we see many patients who are initially started on higher doses of neomercazole, then they land up with severe hypothyroidism, both clinical and biochemical. So this is the reason as we simultaneously started methylpred also. And we have counseled her for getting regular with her follow-up also. So probably on her next follow-up visit with recent CSHFT4, we will escalate the dose as well.
Okay, thank you.
Thank you. So I think there are a couple of questions. So I think most of those you have all answered already. Few people have commented why the FNAC of cold nodule was not done. So you have already mentioned that. Few have written about is there is a possibility of this cold nodule being cancer, thyroid cancer, and resulting in growth hormone excess. Is there any report? What sort of tumors, for example, if we talk about ectopic acromegaly, what sort of tumors are most common resulting in ectopic
So
acromegaly?
yeah, mainly we have small cell lung carcinomas, pancreatic tumors, and mainly neuroendocrine tumors, anywhere in the GIT and within the lungs. They're usually produced with growth hormone releasing hormone axis and resulting in. And yes, this was a very good question, that coal nodule, that can be also a source. So only time would reveal that. And once we are done with thyroidectomy, and biopsy would be seen in that regard also.
Okay, so one question from me: how can you differentiate either, for example, if there is any tumor which is causing ectopic acromegaly, how can you differentiate either it is secreting growth hormone or either it is secreting growth hormone releasing hormone?
So GHRH would usually be present with pituitary hyperplasia, because it will keep on stimulating pituitary for making the hormone. That's the reason. And ectopic, wherever it would be found, there would be some systemic clinical features of that tumor also.
So for example, on the MRI, will there be any difference if there is a ectopic growth hormone secretion or ectopic?
Somatotroph hyperplasia is expected in
which one?
ectopic GHRH.
Yes. And then with the growth hormone?
It would usually be not.
Yes, that's great. Thank you. Thank you very much. So now over to Dr. Atif. Atif, now you can take the lead, and we can do the last one.
Okay. So thank you very much, Vikas. Thank you all trainees who have presented so far. Please keep us updated with the progress of these really interesting and challenging cases. So we are on time. We should be finishing by 4:30. So we're up to the last trainee. So I request Dr. Bharta from JPMC and Medical Institute of Diabetes and Endocrinology to present her case. So over to you, Dr. Bharta.
Assalamu alaikum. Am I audible?
Yes, you are. Go ahead.
Okay. Assalamu alaikum. I'm Dr. Bharta Rani, and I'm an endocrine fellow at Jinnah Postgraduate Medical Center and Medical Institute of Diabetes, Endocrinology, and Metabolism. Today, I'm going to present a case of MEN1 syndrome, presenting with renal stones, spontaneous hypoglycemia, and subclinical Cushing syndrome. So he was a 49-year-old gentleman who presented with complaints of recurrent episodes of dizziness and increased sweating and recurrent kidney stones since 2017. He underwent lithotripsy for the renal stones once in 2018. Along with that, he had complaints of episodic loss of consciousness in the year 2019. On these occasions, he had documented low blood sugars of around 40, 54, and 68 milligram per deciliter. He had no history of headache, blurring of vision, seizures, or trauma. On examination, his heart rate was around 86 per minute. Blood pressure in supine position was 150 by 80, whereas on standing it was 140 by 80. His BMI was 23.8 and his random blood glucose was 90, whereas his systemic examination was entirely unremarkable. So we ran a few subset of tests considering his symptoms. He had a spontaneous hypoglycemia at a fasting blood glucose with a fasting blood glucose of 24 with inappropriately raised insulin and C-peptide. He had raised calcium, raised PTH along with normal albumin. Calcium got it settled or it decreased with hydration. His creatinine initially was 1.6, which normalized after hydration. His prolactin initially was raised, whereas LH, FT4, and cortisol was within the normal limits. So we proceeded with the imaging. His CT scan abdomen and pelvis with contrast reported enhancing heterogeneous mass in the body of the pancreas, which measured approximately 4.1 into 3.6 into 3.7 centimeter, abutting portal vein, inferior vena cava, duodenum with loss of fat planes. The CT scan also reported multiple heterogeneously enhancing lesions with low attenuation in left adrenal gland. The largest one measured 3.4 into 2.7 centimeter with a Hounsfield of -28 in the portovenous phase. Two similar lesions were also noted in the right adrenal gland. Largest one measured 1.8 into 1.5 centimeter with a Hounsfield of -51 in the portovenous phase. Obstructing calculus was noted in the distal left ureter with mild hydroureter and hydronephrosis, whereas two non-obstructing calculi was also noted in the left kidney. MRI pituitary with contrast was done that reported normal sized gland with no evidence of micro or macroadenoma. His MIBI scintigraphy reported functioning left parathyroid adenoma at the upper pole of thyroid gland, and his DEXA scan reported a Z-score of -1.4 at hip and -1.7 at spine. So considering this enhancing lesions with low attenuation in adrenal gland, we ran a few subset of tests regarding adrenal hormones. His urinary cortisol was raised, his ACTH was 8.8, whereas electrolytes, metanephrines, normetanephrines, aldosterone, renin, done on 2 occasions were entirely normal. Whereas DHEA sulfate done on 2 occasions was low, with a DHEA sulfate ratio of less than 1.12. His overnight dexamethasone suppression test came out to be 2.7, and his high dose dexamethasone suppression test came out to be 3. So considering these investigations, and basically his diagnostic criteria of subclinical Cushing syndrome was met as per Japan Endocrine Society and Italian Association of Clinical Endocrinology, whereas 3 out of 4 criteria of Endocrine Society and European Society of Endocrinology were met. So considering this is the imaging, that is CT abdomen, you can clearly appreciate a mass in the body of in the head of the pancreas, particularly in this contrast image, and you can clearly appreciate the adrenal gland on the left, and in this the right. So his endoscopic ultrasound and biopsy was done, which reported a well-circumscribed homogeneous lesion in the head of the pancreas, which measured around 3 into 3.2 centimeter with no vascular involvement. The biopsy of which reported well-differentiated neuroendocrine tumor of grade 1. So he was started on diazoxide, 25 milligram initially thrice a day, and the dose was escalated as he was having persistent hypoglycemia episodes with that. Surgery couldn't be proceeded initially, and for his hypercalcemia and for his raised home blood pressure readings, he was started on furosemide and amlodipine. He was started on alendronate by some physician in the periphery because of his hypercalcemia. He was started on sertraline because he had some depressive illness because of these persistent hypoglycemia episodes, and he was advised to have to take more fluid and to have small frequent meals. So in the case resolution of follow-up, we would do the family tracing for Menon syndrome. We would screen for pituitary tumor later if it is clinically indicated. We would do the surveillance for recurrence of insulinoma after the surgery is done, that is 3 to 12 months post-resection with history, physical examination, tumor markers, and imaging as clinically indicated thereafter. Regarding parathyroidectomy, if just the adenoma removal is done, then of course replacement therapy temporarily, or if the total parathyroidectomy is done, then it would lead to permanent hypoparathyroidism, and replacement with calcium and active vitamin D would be done. And bisphosphonates for osteopenia. So this is basically our discussion point, either they should be continued or not. So my discussion points are, we should move for adrenal venous sampling to lateralize the source of excess cortisol secretion. Should we continue bisphosphonates in this patient regarding for osteopenia, considering the subclinical Cushing syndrome? And what should be the sequence of surgery here? And for the parathyroid thing, either we should go for just for the adenoma removal or subtotal parathyroidectomy, or we should go for complete parathyroidectomy with an autograft placement. Thank you.
Thank you very much, Dr. Bhatta. Excellent presentation. So as per our format, let's go through these questions with yourself first. So can I take the third question first? What should be the sequence of surgery here? What would you want to take out first and why?
First of all, I would love to go for insulinoma surgery as it is a life-threatening condition. Patient is having the recurrent hypoglycemia episode, so that surgery should be proceeded first. And along with that, if the adrenal venous sampling is suggestive of the excess cortisol secretion from a single gland, from a single adenoma, then we can proceed for unilateral adrenalectomy along with that, and we do the parathyroid surgery in the second go.
Okay, but the adrenal venous sampling would more or less lateralize the gland for you. It may not be able to lateralize the nodule for you. So anyway, but that's an interesting thought. So let's go down your list. You've got bisphosphonates for this patient for osteopenia.
Yeah.
And the cause of osteopenia in this case is the hypercalcemia and the hyperparathyroidism, right?
Could be.
So yeah. So how long and what you want to continue the bisphosphonates for, and what's the evidence for using bisphosphonates? Because this is kind of secondary osteopenia with a cause, right?
Yes, of course. But as soon as the cause is removed, we can just repeat the DEXA scan and we can see, because this patient has concomitant subclinical Cushing syndrome as well. That can also be the cause of his osteopenia. So we need to consider that as well. I find out the literature in which I saw that weekly first generation bisphosphonate was given to a patient with osteopenia due to subclinical Cushing syndrome, and that increased his BMD at lumbar spine as well as femoral neck.
Okay. Look, going on to your last question, removal of parathyroid adenoma, you have got a clear surgical target on the functional scanning that you've done. So, but still you're thinking of a complete parathyroidectomy. Why is that?
Because this patient is a MEN1 syndrome. We are labeling him as MEN1 syndrome, in which there are chances of persistent hyperparathyroidism and recurrent hyperparathyroidism. So there are two schools of thought in MEN1 syndrome, that either you should remove 3.5 glands, that is subtotal parathyroidectomy. But if the surgeon's expertise is there and you are working in a good setup, then you can even go for complete parathyroidectomy, so that there are no chances of recurrent hyperparathyroidism in future. But still, I found an article that mentioned that even an autograft placement, when you place an autograft, that can also cause recurrent hyperparathyroidism in MEN1.
Okay, fine. Thank you very much. Let's go to our panelists. Dr. Abbas, please.
Again, I'm impressed by the quality of presentation by all the fellows, including yours, Bharta. One quick question. Do you think there is any way of intraoperable ways of looking into if the parathyroid has been taken care of during an operation, or do you have to rely on the follow-up of these patients if the parathyroid was taken care of?
No, there is some method for intraoperative localization, that the parathyroid, once the adenoma is removed, once the parathyroid gland in which there is adenoma, then they can see the frozen sections of the other glands and then keep on removing the other glands.
Are you aware of anything else other than intraoperable doing the frozen sections?
Intraoperative PTH?
And how would that imply to the treatment?
That can help, of course. If the intraoperative PTH is raised, then we need to remove all of the 4 glands, all of the glands. Sorry.
So you're partly right. So, but I was looking for it that even if when you have a drop of PTH during operation of more than 50%, you're probably getting the tumor out. That's one way of looking at it. There are also ways that you can actually put a probe during operation and try to localize the hyperactive adrenal parathyroid glands as well. You inject the same dye, just like a system AB, and then you put the probe, and whichever lights up more, you'll get the better answer. So there are ways that during operation you can find it out. But your point is very well taken, that even later on, anyone can wake up and start making more of parathyroid hormone.
Exactly.
Over to you, Atif.
Thank you. Over to you, Dr. Shahid.
Very good presentation, Bharta. I have one. How do you say that if there is excess cortisol secretion, in your opinion, how do you say that it's from adrenal?
Because it is actually meeting all of the
criteria. It's not a pituitary dependent.
Sorry?
How do you say that it's of adrenal origin and it's not due to a pituitary dependent disease?
Because I found out the criteria, though, so in my case is particularly meeting those criteria. That is, first there should be a presence of adrenal.
What is the level of ACTH in those criteria for
the cutoff is
it to be from
10.
adrenal origin?
The cutoff is less
ACTH.
than 10. Yeah, the cutoff is less than 10 and mine is 8.8.
Acha.
Yeah.
Less than 10 or less than 5?
Less than 10. I just reviewed all of the society guidelines. It was less than 10.
Okay.
Yeah.
But it is, patient is not cushingoid.
Yeah.
And there is marginal abnormality in the overnight dexamethasone. You should go for low dose dexamethasone suppression test, I think.
Actually, the thing was
it has a better yield. It has a better yield than overnight dexamethasone suppression test.
Yeah, agreed. But the thing is
We
that,
consider low dose dexamethasone as a gold standard.
yeah, first of all, I want to make the one thing clear that you said that this patient doesn't have Cushing's. So that is one of the criteria of diagnosing this patient as subclinical Cushing's. That patient should not have any condition related to Cushing's syndrome, excluding the features which are not part of Cushing's include hypertension, general obesity, dyslipidemias, or impaired glucose tolerance. So this is our criteria. The other thing basically would be that you said low dose. Yes, that is a part, but that is a screening test. So screening test, we can just do one of the screening tests, either 24-hour urinary free cortisol or low dose dexamethasone suppression test. So we have already done that 24 urinary free cortisol. Am I audible?
24-hour, no. 24-hour urinary cortisol is significant only when it is threefold. There is a threefold rise. You have just marginal rise in 24-hour urinary cortisol. So you should do low dose dexamethasone. And moreover, the adrenal tumors in MEN1 syndrome are rarely cortisol producing.
Agreed. They are particularly non-functioning. Agreed to this.
These are producing or non-functional. So
Dr. Shah, your voice is breaking up a lot.
Maybe we can go to Dr. Zaman again.
Dr. Zaman, over to you.
Okay.
Dr. Zaman, over to you. Okay, let me just check.
Okay, I have finished my question. Okay, thank you.
Okay. Dr. Zaman, are you here? He might have some issues as well. I can't see. He might have.
I think he's disconnected.
Yeah, some connection issues. Anyway, let's see. So there is. So let's take the questions from the audience or comments from the. So one of them is to localize a functional adrenal tumor. You can request nor cholesterol scan to your nuclear medicine colleague. Okay. Moving on to the next excellent case. Is there not high risk of Hungry bone syndrome after surgery if we continue with bisphosphonates pre-operatively? Is vitamin D replete, Dr. Bharta?
So that is what actually my question is, that should we continue or we should just stop it? That is the point of discussion. Yeah,
I think what the person is trying to highlight is just make sure this person is vitamin D replete before you operate upon the parameters.
Of course, we are doing that.
Excellent. Okay, thank you very much, Dr. Bharta. So with that, ladies and gentlemen, we come to the end of this session, and good timing. We have finished in time. I would just request our worthy panelists if they can just do the total on the sheets and maybe just send me a quick picture of their marking sheets over WhatsApp so that we can announce the winner here. And meanwhile, while we wait, we're already getting some sheets. Brilliant. Okay, so Vikas, are you there? You want to take over for a minute or so to maybe entertain the audience while I do the calculations?
Okay, so I am here. Let me see if there is any other questions. Great. So they have mentioned about the vitamin D. if anyone have any more questions, they can ask in question and answer session, and we can ask from any of our participant if there is any question from any.
So while we have the audience right here and while we have the fellows around, I have a quick comment. I think everyone did a wonderful job, and usually these presentations are not to grill or not to show anyone's more capabilities or more in-depth analysis of endocrinology. It's just to improve the confidence and the level of expert. And even if you're criticized, it's not for the sake of criticizing, it's just for you and us to learn. So hats off to everyone for coming up with this. And I think this is an initiative that we should do more often for training of our fellows.
Yes, thank you, Dr. Abbas. And yes, it is mainly to improve presentation skills, and people can ask questions in these forums. And I'm very pleased that we have wonderful presentations, and we still have more, which we will arrange another session. But it was really a good session and very good presentations. We will soon have the results. I think our panelists have completed the result sheets, and Atif is preparing.
Yes, Vikas, just last few seconds, just let me get my calculations right. Dr. Zaman had some technical issues, so I've just spoken to him over the phone. I've got his sheet down with me as well. So okay, so we now have a winner. Let me announce the winner, and everyone participated so well. I hate to announce a winner. But just for the sake of formality, everyone is a winner here. Really, everyone is a winner. Very well done, all the trainees. So the winner for today's event is Dr. Bharta from JPMC. So I think a big round of applause from wherever we are for Dr. Bharta. And excellent presentation, very well done. Everyone else did really well as well. So the prize Dr. Bharta is going to get is it's a very academic prize. So you're going to get the latest version of Williams textbook of endocrinology from us, along with a certificate of participation from Pakistan Endocrine Society. Everyone who has participated will get a certificate, but obviously for the sake of formality, it has to be just one winner. But for us, everyone is a winner. Just to close things off, I would like to thank everyone, your supervisors, yourself, our worthy panelists, and we'll take some closing remarks from our two panelists and from Dr. Vikas, and then we wind off. So Dr. Abbas.
So again, great activity, had a good job, fellows, and I congratulate Bharta for presenting it wonderfully. Honestly, it was a very difficult decision from panelist point of view to make one person more or give more points to one person or the other. But hats off, congratulations, and wish you all the best.
Dr. Shahid, please.
It was a very good session, Atif, and all the presenters were very well prepared, cases were very good, and we have learned a lot. It was a very good session. And congratulations to all the presenters.
Thank you.
And especially Dr. Bharta, yes.
Yes, Dr. Vikas.
Congratulations to Dr. Bharta and everyone. All presenter have done a really good job. All the cases were very good and challenging, and they all prepared it very well. So that's a brilliant session, and I think we are looking forward for the next session, and hopefully we will have these sort of session regularly as a part of our training program. So everyone take part in these sessions regularly, and this is a very good learning exercise.
Thank you very much, everyone. And a special thanks to Hilton Pharmaceuticals for, as always, coming along up with all our academic activities. So let's finish off with Dr. Bharta's winning speech.
This is the most difficult part, I would say. Thank you so much. It was really a good learning opportunity. And of course, the great part to mention here is Dr. Tasneem Ehsan, who is my supervisor. And like, she helped me a lot in like guiding me and everything. And this was really a good forum or platform for learning. And thank you for such precious gift.
Welcome, welcome. So thank you, everyone. Take care. Have a nice weekend or whatever is left of the weekend. Allah Hafiz. Thank you.
Thank you.